All right, so we'll go and get started. I want to thank everyone for tuning in this week to our e-lecture series lecture. Just a little bit of housekeeping before we begin. This webinar and all the lectures on the series are for educational purposes only. All the interactive features for attendees have been disabled to ensure optimal quality for all viewers. If you have questions, please email us at this email address, emorymskradiology@gmail.com. The speaker today has been kind enough to agree to do a question and answer session at the end. And so any questions you have, please email us here and we will ask those questions at the end. If you raise your hand or attempt to do any other interactive features in the Zoom platform, unfortunately, that will not be able to get through to the speaker. So please email this email address. This video will be recorded and will be uploaded to the YouTube channel. A reminder, attendees have not been given permission to screen record any of these talks, which may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. With that, I'm going to introduce our speaker today. We have the pleasure of having Dr. Mohammad Samim. He is an assistant professor of musculoskeletal radiology at the NYU School of Medicine. He completed residency at Yale, followed by a fellowship in musculoskeletal imaging and intervention at Brigham and Women's Hospital. He is heavily involved in MSK research and has authored many peer-reviewed scientific articles, written book chapters, and presented at radiologic and orthopedic surgical national conferences. He reviews for several journals and has recently been involved in funded research projects. Dr. Samim is active in MSK education and is frequently invited to speak at regional events and CME courses. He has received many accolades related to his work, including an RSNA Certificate of Merit for his presentation on MR imaging of superior capsular reconstructions, which may relate to his talk that we hear today. We are delighted to hear him speak, and with that, I will turn it over to Dr. Samim.
Good morning, everyone. Thank you, Adam, for your kind introduction. And it's such an honor to be here and to be able to talk to you this morning. And again, thanks, Adam and the Emory MSK section for inviting me and giving me this opportunity. So I'm going to talk about MRI of massive rotator cuff tear repair. I do not have any disclosures, and without further ado, we can start. The emphasis of this talk is on MRI, and I'm going to go over massive rotator cuff tear definition and challenges of its treatment, what is considered irreparable rotator cuff tear, what are the available surgical options, what would be the expected post-operative appearance, and we go over some complications of some of these surgical options. So massive cuff tears comprise about 40% of all rotator cuff tears. They are particularly challenging for orthopedic surgeons to manage for several reasons. One is that there are different definitions of massive rotator cuff tear in the literature, which make them difficult to consistently being diagnosed and treat. So the two most commonly used definitions are a tear measuring 5 centimeter or more in the coronal plane on MRI, and the second one, which is probably used more, at least among us, is the full thickness tears involving at least 2 adjacent tendons. There are also technical and biological challenges associated with the repair of massive rotator cuff tears, including poor quality of the retracted inelastic tendon tissues, scarring, muscle atrophy, and fatty degeneration of the cuff muscles. Massive cuff tears are usually associated with a poor outcome even after controlling for other factors after primary repair, including a higher rate of re-tear. In terms of surgical treatment options, there are different surgical treatment options available for symptomatic massive rotator cuff tears. We are going to talk about first repairable tears, and we'll get into the irreparable massive rotator cuff tear repairs later during the talk. So for repairable tendon tears, the idea is whenever feasible, a complete primary anatomical repair should be performed. So let's talk about primary repair. But before that, I just want to touch upon the role of MRI, which is the modality of choice to assess shoulder cuff after surgery. Obviously, ultrasound is a great tool as well. CT arthrogram can be used, obviously. But MR, I think, is used more commonly than any other modality in the country. One of the challenges of postoperative MRI is the presence of metal, which can be obviously reduced using modified metal reduction protocols. Although I have to mention that most recent orthopedic hardware used in arthroscopic shoulder surgery is made of titanium, and that is significantly reduces the artifact resulting from hardware compared to the older orthopedic hardware made of ferromagnetic metals such as stainless steel or cobalt chrome. Um, direct MR arthrogram, despite being invasive, can improve diagnostic accuracy for the postoperative shoulder via distending the joint and increasing signal to noise ratio. We're going to talk about MR arthrogram as well in a minute. Yeah, so the rotator cuff tear is considered repairable if surgeon is able to perform primary repair of the tear, meaning that the tear should be reducible to the graded trochanter. Um, in addition to imaging criteria, um, the decision to perform a repair of rotator cuff tear generally depends on several other clinical factors. Those include duration of the symptoms, duration of the failure of non-operative treatment, nocturnal pain, history of trauma, and limitation of the daily living activities, and what kind of activity the surgeon and the patient would like to achieve after surgery. I mean, the expectation would be different from an active, maybe athlete patient from a older individual who does not have such an active lifestyle. And in general, repair is usually not indicated when there is a fixed humeral head elevation, non-functioning deltoid muscle, and advanced rotator cuff muscle atrophy or fatty infiltration, which surgeons can assess during the physical exam. In terms of imaging criteria, from imaging perspective, the rotator cuff tear is considered repairable, and that is based on the size of the tear, number of the tendon involved, quality of the tendon and muscle. That should allow surgeons to perform primary repair. And again, these tears should be able to be reduced to greater tuberosity, footprint, and they do not meet the criteria for irreparable massive rotator cuff tear that we will discuss in details in a few minutes. There are different types of primary repair. The morphology, thickness, and orientation of the tear can determine the type of repair. For example, the small partial thickness tears are typically treated with debridement. The longitudinal tears oriented in the long axis of the tendon are treated with the tendon-to-tendon suturing, such as in this example. While higher partial thickness or full thickness tears are treated by attaching the torn tendon to the greater tuberosity osseous footprint. Oftentimes, surgeons may convert a partial thickness to a full thickness tear during surgery and then treat that as a full thickness tear. The tendon attachment to the osseous footprint is performed using different material, but in terms of suture technique is either a single or double row of sutures placed in the tendon and along the medial and lateral margin of the footprint. In general, the double row repairs have a significantly higher rate of intact tendon healing compared with the single row repair. So what is the expected post-op appearance? The expected appearance of the post-op rotator cuff tendon is variable and depends on the stage and duration of the underlying disease process and the time interval between the MR imaging and surgery. One of the major challenges of evaluating repair rotator cuff tendon tear is that the intermediate signal or little bit of disorganized appearance of the tendon fibers can be expected finding and does not necessarily indicate recurrent or residual disease, such as tendinosis or partial tear. And interestingly, they do not even correlate with the clinical outcome after surgery. So in general, intact repair tendons are usually thinner earlier and thicker later than normal tendons and contain areas of increased T2 signal, which could be due to granulation tissue, some fibrosis, suture material, or metal artifact, depending on the material they used. The signal changes involve almost 90% of the repair tendons and starts improving between 3 to 12 months following surgery, although it can persist for several months in certain years. Uh, Therefore, it is really important not to consider a tendon re-tear following repair, specifically within the first few months and sometimes up to the first year from surgery based on just a tendon irregularity or just a little bit of thinning and a signal heterogeneity, which can be expected post-operative appearance. There are also some expected osseous changes following surgery related to the bone reaction to the suture anchors, include T2 signal hyperintensity of the greater tuberosity at the region of the suture anchors. And this signal usually making last for years following surgery in asymptomatic patients. I'm going to show you some examples of those. Another post-op change which can create a pitfall in terms of interpretation of the MR is that the flattened and abnormal morphology of the greater tuberosity can be expected as surgeons create an implantation trough, which can mimic Hill-Sachs impaction. Here is an example of a normal expected appearance of the repaired primary tendon repair, showing a heterogeneous, slightly thick tendon, but if you see there's otherwise the tendon is completely intact. There's no fluid gap in the tendon or at the footprint. In terms of complication of the primary repair, re-tears and shoulder stiffness are the two most common complications following rotator cuff repair, but there are other complications. For the most part, I'm just gonna focus on the re-tears of throughout my talk of the tendon repair, and when we get into the massive rotator cuff tear irreparable cases, I also try to focus on re-tears. In general, the greatest predictive factor for re-tear is the size of the original tear. So meaning that with larger AP dimension or higher grade of tears, retraction posing the greatest risk for re-tear. MR, the sensitivity and specificity of conventional MR for post-op rotator cuff is about 85 to 91% for full thickness tears, and a little bit on an average lower for the partial tears, which is understandable. Imaging findings of rotator cuff re-tears are similar to those of original tendon tears, including a gap in the repaired tendon tissue with fluid signal or contrast material extending into or through it along the absence of the heterogeneous repaired tendon at the expected sites. So most re-tears of the primary repair are due to failure of the tendon healing as a result of poor tissue quality, or which is, see in this example, this is a patient who had primary rotator cuff repair. This is 4 months following surgery, and you see on the coronal and axial proton density fat set images, there's a delaminating full thickness re-tear of the supraspinatus tendon with retraction. But for the most part, the suture anchors are still in place. Notice there is marrow edema or edema-like signal around the suture anchor in the greater tuberosity, and that is expected postoperative appearance. Oftentimes, you may see a little bit more focal fluid signal surrounding the suture anchors. That may be seen also due to hydrolysis effect of the anchors, and they usually replaced by bone within the first 2 years of surgery. So if you see those, just be careful about calling anything like osteolysis in earlier stages. In addition to failure of the tendon healing, the second most common reason for re-tear is the fixation failure, which could be either in the bony anchor pullout or suture breakage. Here is an example. This patient had a primary repair of the rotator cuff tendon, and you see on the coronal PD, there's a full thickness re-tear of the repaired supraspinatus tendon, which is now retracted to the level of the humeral head apex. There is susceptibility artifact related to the tendon, which is related to the suture material. And you see that there is an empty screw tract in the supraspinatus tendon footprint, and you can see the displaced screw in the deltoid muscle. Just remember, if they're in hard cases, you can use other secondary clues indicating failure of the repaired tendon, which are the absence of the tendon bulk at the expected footprint insertion of the greater tuberosity, abnormal morphology of the tendon and its myotendinous junction, and progression of rotator cuff muscle atrophy and fatty degeneration. Here's in a patient with repair rotator cuff tear, and you see on the coronal PD and sagittal PD fat side MR images, there's a retracted full thickness re-tear with intermediate signal intensity, scar, and granulation tissue along the expected course of the supraspinatus tendon. So these can be difficult to sometimes make the diagnosis of the full thickness tear a little bit difficult. And oftentimes, things which can help us would be MR arthrogram in these cases, or maybe just making sure that really there's no evidence of tendon fibers in this location. But let's see if we can see other findings here which can help us, which would be we can see in this example, and that's a little bit of osteolysis around one of the anchors. You notice that this anchor has pulled out from the bone surface, and there is an area of lobular signal, like fluid signal around the tip of the suture anchor, which suggests there is an osteolysis and loosening of the anchor. Regarding MR arthrogram, the joint distension and fluid coating the tears in MR arthrogram allows diagnosis of the recurrent tears with overall better sensitivity and specificity. MR arthrogram also can help differentiating granulation tissue from real tear when contrast fills in the tear and not the granulation tissue. I think I have an example of that. It's very important to remember that presence or absence of the contrast in the subacromial subdeltoid bursa does not necessarily indicate there is a re-tear or there's intact repaired tendon. Most rotator cuff repairs are not watertight, which is not required for a favorable clinical outcome. Therefore, if you see contrast communicating with the subacromial subdeltoid bursa without a definite tear, this can be normal. On the other hand, contrast may not sometimes communicate with the subacromial subdeltoid bursa, even in the presence of recurrent full thickness rotator cuff tear. And that's because sometimes we have a very thick fibrosis in the scar tissue, which can basically stop the contrast to go from the articular surface to the bursal surface. Here is an example. Patient had primary rotator cuff repair. This is an MR arthrogram. On the coronal PD fat side arthrogram image, you notice there's an intermediate signal intensity granulation tissue between the suture anchor and the rotator cuff. Repaired tissue creates an appearance of perhaps a partial thickness tear, but on the coronal T1 fat side image, sort of on the same slice, you'll see that there is contrast actually extending into that defect going into the subacromial subdeltoid bursa. That indicates there's a full thickness re-tear of the repaired tissue. Also interestingly, you can see the contrast filling around the anchor that is suggestive of osteolysis around the suture anchor. And you can see that on the PD fat side as fluid signal around the tip of the anchor. I just want to mention here that there is an MRI-based classification system. Maybe there are more than one. That was introduced by orthopedic surgeons, Japanese Sugaya and colleagues to evaluate for repair tendon thickness and discontinuity. I think this classification can provide a guide on what to look for and how to report the tendon status. You don't really need to report the type of the or grading of the Sugaya, but maybe something that can help us when we are doing interpretation of these. Classification has shown to correlate well with patient functional outcome and has shown good inter-observer and intra-observer agreement for detecting full thickness or partial thickness tears. So type 1 and 2 are pretty much intact repair. Type 5 is presence of major discontinuity or full thickness, which can be seen in more than 2 slices. And type 3 and 4 perhaps can sometimes help us to basically decide which direction you want to go. The type 3 is an insufficient thickness with less than half of the thickness of the repaired tissue left when compared with a normal cuff without discontinuity. And type 4 when there is just a small discontinuity in one or two slices, suggesting a small full thickness tear. So I'm just going to show you some examples here. This is a woman after primary rotator cuff repair. This is an example of the Sugaya type 2, which is essentially intact repaired supraspinatus repaired tendon tissue, showing there's no discontinuity and a little bit of intermediate signal in the repaired tissue. Example of 2 different patients showing example of Sugaya type 3 re-tear of the repaired tendon. On the left, there's an insufficient thickness with less than half of the thickness left when compared to the normal cuff. And you can see the retracted partial thickness articular-sided delaminating tear here. One caveat here, I don't think this was a case for this patient, but always you want to refer to the op note to just make sure the surgeon did a complete or full thickness primary repair. Oftentimes, they may not be able to reduce the whole tendon to the footprint and just may go for one of the tendon stumps, the articular surface or the bursal surface. So before calling it a re-tear, you want to make sure you refer to the op note and make sure that that was done. On the right, you notice that there is a insufficient thickness and a retracted partial thickness bursal-sided tear of the repaired tissue. And example of the type 5, which is really another diagnostic dilemma. This is a complete full thickness re-tear of the repaired supraspinatus tendon. You notice there's a full thickness re-tear with retraction and fluid gap, and you can start to appreciate maybe some surgical suture material floating between the tendon stumps here. Now moving on to irreparable rotator cuff tears, which obviously in massive rotator cuff tear, primary repair is not always feasible because these tears are typically large in size, have poor tendon quality, of retracted torn tendon with scarring, and have more advanced cuff muscle atrophy and fatty degeneration. There are different surgical options starting from debridement mainly for pain relief, with option of adding biceps tenotomy or tenodesis. This option is usually just for improving function, mainly for more elderly patients when more limited function outcome is acceptable. Then there is reverse shoulder arthroplasty, which is reserved for older patients with massive rotator cuff tear and more advanced glenohumeral osteoarthrosis. And that leaves a subset of patients with irreparable massive rotator cuff tear, which usually are younger, with functional limitation and no substantial glenohumeral arthrosis, who may benefit from repair, partial repair, or augmentation procedures. And those include patch graft augmentation and bridging, superior capsular reconstruction, muscle tendon transfer, and subacromial balloon implantation. We're going to go over these 4. Starting with patch graft, augmentation, and bridging. So grafts can be used to augment repair of rotator cuff tear if there is a concern regarding healing or stretch of the primary repair. Uh, or they can use as a bridge for an irreparable defect. I'm going to go over each of them separately. There are different graft materials being used, including autografts such as fascia lata, allograft, such as acellular humeral dermal graft, xenografts, and synthetic grafts. I'm going to use some of my prior colleagues, Luis Beltran's illustrations for this talk. These are coming from the work that we did together. These are really nice. He's a great radiologist, and also he's a great artist. So I have to give the credit to him. So starting with patch graft augmentation, which is used after completion of primary or at least partial primary repair of the torn tendon when there is a concern regarding healing or too much stretch of the primary repair, as you see in this example. It can be the graft can be placed on the bursal surface as an overlay or articular surface as an underlay graft. And the expected post-op appearance is a low to intermediate signal graft material with no fluid-filled gap. When I say low to intermediate heterogeneous signal graft, I mostly refer to like a allograft or autograft. For more synthetic allografts, usually the signal is pretty low. And as we can see in cases of supracapsular reconstruction that I'm going to show you. So in the cases of augmentation, which I don't think it's that common to see these cases, but when you see these cases of augmentation, the graft may become very it could become very imperceptible and difficult to separate from the native tendon on MR imaging. So that is really important to, if you have access to the surgical node, just to refer to that, just make sure that's what was done if you're suspecting something on the image. This is an example of a patient who had a graft augmentation. Notice on the coronal PD fats and MR, there's the graft is an overlay. You notice that the repair was not completely done. The primary repair was not completely done. As you can see, that they were not able to stretch the repair tissue all the way to the lateral margin of the graded tuberosity. So that's what they ended up using the graft. The graft fills the residual defect from bursal surface after the debridement, and it shows the intermediate MR signal after surgery on both PD fat side and regular PD. Again, I think not. I mean, looks like something sitting there, but I think it can be easily. It's very imperceptible, I think, from the tendon, specifically in earliest post-op stages, and in later stages when it's completely, if it completely integrate with the native tendon, it might be hard to separate the graft. So it is important to basically correlate that with surgical node. Again, there is no fluid gap in the graft or in the repair tendon, so this is completely normal, intact appearance of the patch graft augmentation. In terms of bridging is typically for irreparable defect greater than 1 centimeter and insufficient excursion of the retracted torn tendon. In this method, after adequate debridement of the tendon stump, the residual tendon defect is measured and the graft is prepared and trimmed outside the patient's body to match the size of the defect. And then the graft will be sutured to the residual tendon and the graded tuberosity, as you see in this illustration. Again, normal postoperative appearance is pretty similar to any other graft. Synthetic is going to be dark. Other autografts like tensor fascia lata is probably some sort of some irregularity with heterogeneous signal, and it should not be any full thickness fluid cleft in the graft or the repair tendon tissue. Here is an example of the patch graft bridging. This patient had a massive rotator cuff tear. They were not able to bring the cuff to the graded tuberosity, so they did a debridement. and the patch graft augmentation, patch graft bridging. The medial margin is sutured to the residual supraspinatus tendon and laterally to the greater tuberosity. The graft is taut, and as you can see in this example, also this was an dermal allograft that was used in our institution. It's pretty dark uh, and really doesn't have that heterogeneous signal that we're talking about. So this was I haven't seen many of these, honestly. I think I've seen maybe one or two in our institution. Uh, okay, so moving on to superior capsular reconstruction, which was first described by Mihata, who is a Japanese orthopedic surgeon, as an alternative treatment for patients with irreparable symptomatic massive rotator cuff tear. It ideally should be performed for younger patients with non-repairable rotator cuff tear and no significant arthrosis. I have to emphasize here that it is really important for if we're reading the one of these cases of massive rotator cuff tear, we have to be try to provide as much information as possible in terms of glenohumeral uh, articular surface and arthrosis, because that significant arthrosis markedly impact the outcome of these surgeries. Original graft used by the Japanese group was fascia lata autograft. More recently, dermal allograft has become more popular, specifically in in the States, as it reduces donor side morbidity and surgical time. In general, the dermal allografts are thinner than the fascia lata. Fascia lata is as twice thick as the dermal allograft when they use it for SCR. A little bit about how SCR was developed and a little bit about background. Another Japanese surgical orthopedic surgeons demonstrated in a biomechanical study that a deficient superior capsule increased glenohumeral translation in all directions, most notably superior translation, as we can see in our imaging and radiographs and MR. Mihata and his group also, in a simulated non-repairable rotator cuff tears and repair, demonstrated that superior glenohumeral translation was partially restored after applying a patch graft to the supraspinatus tendon, but it was fully restored after the graft was applied to reconstruct the superior capsule. And they concluded that the patch should be attached medially to the superior glenoid instead of the supraspinatus tendon stump and lateral to the greater tuberosity. So that was how superior capsular reconstruction idea was developed. So how the surgery is done. So during superior capsular reconstruction, um, the graft is obviously outside the body. The surgeon started to do the debridement of the rotator cuff, and after the debridement is done, they're going to measure the distance between the glenoid and the greater tuberosity. And based on that, they're going to measure the graft. They usually basically include a larger graft because they put the stitch a few millimeters from the edge of the graft. Also, they include a little bit wider graft in case they want to do a side-to-side attachment. They put in anchors. Usually anchors are at the glenoid side is approximately at 10 o'clock and 2 o'clock position of the graft on the clock face. And the anchors placed in the greater tuberosity. At our institution, they do a double row. So you'll see 2 rows in the greater tuberosity. They shuttle the graft inside the body, and they put the anchors in the greater tuberosity and the superior glenoid. Oftentimes, they do side-to-side anastomosis or attachment posteriorly to the whatever is left from the anterior infraspinatus, and often anteriorly to what they called as a common tissue or residual of the subscapularis sometimes, or some capsular tissue anteriorly. Very important if you're reading one of these, just to refer to the up note, just and make sure they have done side-to-side attachment if you're concerned about side-to-side attachment, anastomosis tear, because not always and not all surgeons do the side-to-side attachment. So the goal of the supracapsular reconstruction is to prevent superior humeral head translation leading to rotator cuff arthropathy by reconstructing the superior capsule, the superior aspect of the glenohumeral joint capsule. So it should function as a superior capsule. And I emphasize that because I will show you some examples that the graft is not really, is still kind of intact, but is not acting as a superior capsule. The other mechanism that supracapsule can cause some pain relief and improve function is because it can act as an spacer underneath the acromion, which basically create a fulcrum, increasing the deltoid mechanical advantage, similar to the early use of synthetic material for cuff repair, or a bit similar to the notion of reverse shoulder arthroplasty, which create more fulcrum and more functional arm for the deltoid to function. So that's another reason that supracapsular reconstruction can improve function. So what's the normal postoperative appearance of supracapsular reconstruction? Again, depending on what kind of graft they use, you would expect to see low signal or maybe intermediate signal. The tendon should be taut, should not have any fluid signal discontinuity. It should have an intact attachment. So things that you want to check is whether the glenoid attachment is intact, the humeral attachment is intact. The graft should normally cover a portion of the superior humeral head. And if there is any evidence or any signs of side-to-side attachment, you want to make sure that that is also intact. Here is an example of an intact superior capsular reconstruction, coronal and sagittal PD fat set images showing that the intact, those are dermal allograft. As you can see, there's pretty dark, homogeneous signal graft. The glenoid attachment is intact. The humeral attachment is intact. It is covering the humeral head apex. On the sagittal, similarly, it's very important to look at it on the sagittal, showing the graft covering the entire superior humeral head. Patient had a side-to-side attachment, as you can see here. This is the residual of the infraspinatus tendon that they managed to grab and stitch it to the side-to-side attachment. Just for fun, you can see the majority of the graft on the axial image that showing the porosity of the graft material. One caveat I would say in interpretation of these grafts is that there are often small suture holes in the graft, which sometimes can be seen more than 5 millimeters from the medial and lateral edge of the graft substance, and these are related to suture holes. These should not be considered tears or perforation, as you can see in these examples, like small holes, specifically around the margin of the graft. We had a case that also had and this example had a sort of a small suture holes here, but if we were scrolling going from this slice anterior to posterior, the graft was completely intact. So be aware of those. Some examples of failure of the supracapsular reconstruction. This illustration shows the detachment of the dermal allograft at the medial margin of the graft from the superior glenoid. That occurs in association with superior translation of the humeral head from glenoid. And similar example on the coronal proton density fat surface MR image showing complete detachment of the medial margin of the graft from the glenoid. The humeral attachment is partially intact. And the reason is that once one of the anchors at the side of one of the anchors, you can see there is graft material, and in the other anchors, there's absence of the graft material attaching to the suture anchor, and the suture anchor is slightly backed out from the surface of the bone. One challenge in these cases is that majority of these patients had prior rotator cuff repair, primary rotator cuff repair, if not once if not twice, at least once or multiple times. So it's not unusual to see so many anchors in the humeral head and make it difficult to realize or just to identify the anchor related to the superior capsular reconstruction. If you have a prior MR or pre-op MR, that will help you to identify which suture anchor is related to superior capsular reconstruction, and then you can scrutinize presence of the graft at the region of those suture anchors. Always look for superior translation of the humeral head in these cases. That will tell you that probably this capsular reconstruction is not doing its job, because the idea, as I mentioned earlier, is that basically to act as a superior capsule and keep the head of the humeral head low. And same patient who had a failure of the superior capsular reconstruction showing elevation of the superior humeral head, elevation of the humeral head. Another example showing fluid gap between the medial margin of the graft and the glenoid consistent with the tear. There's retraction of the graft on the axial proton density fat surface image. There's the tear is partially, the graft is partially intact, but you can see there's a detachment of the graft from the posterior anchor. Notice there's a loose anchor in the deltoid related to prior rotator cuff repair. Tear can also happen at the side-to-side attachment, as illustration showing nicely here. Again, you want to make sure that it was done before calling it was a tear. At our institution, I know that our surgeons, basically there are two surgeons who do these procedures. They like to try to do these attachments as close as to glenoid. So when it comes more lateral, we tend not to call any, if we see any gap between the graft and the muscle or tendon, we tend not to call any tear. But close to the glenoid, if that was done, if the side-to-side attachment was done and there is a gap, we try to highlight that in our report. Here's an example. You can see in the coronal proton density, the humeral attachment is intact. I'm not showing you the glenoid attachment. The glenoid attachment was also intact completely. On the sagittal proton density fat suppressed image, you see that there's tear of the side-to-side attachment. You see there's a fluid gap, or maybe this was contrast. There was a contrast, there's a gap between the graft and the posterior or anterior margin of the infraspinatus. We know that there was a side-to-side attachment in this case. You notice that there's a location of the graft is not at the superior superior humeral head. It's basically posterior superior, covering the posterior superior aspect of the humeral head. And technically, that this graft is not functioning as the superior capsule. So it is important to check the position of the graft on the sagittal as well. Another example of the tear of the medial margin of the graft from the glenoid and intact humeral attachment. As you can see, the graft is on the humeral side, it looks like intact, but when you look at the axial or even sagittal, you notice that the graft is not really where it's supposed to be. It's basically completely displaced, covering the posterior aspect of the humeral head. Again, it is important in these cases, if you notice the glenohumeral articular surface, there's a broad full thickness cartilage defect. And if you see that, you just definitely want to mention or highlight it in your report, because this is one of the factors which can negatively impact the outcome of supracapsular reconstruction. And surgeons usually do not consider this surgery when there is high-grade glenohumeral osteoarthrosis. Moving on to muscle tendon transfer. Again, this is another alternative surgical option, usually considered for younger patients with non-reparable symptomatic massive rotator cuff tear without glenohumeral osteoarthrosis. There are several tendon transfers have been developed. The selection of the tendon donor site is based on a structural deficit and impaired function. There are important principles which I found very interesting, so I just want to mention here. When they want to consider designing the tendon transfers, and that include the transferred and recipient muscle should have similar excursion and tension and similar line of pull. Transferred muscle should be expandable, and tendon transfer should be planned to replace only one function of the recipient muscle. For example, if there is a deficiency in the posterior superior rotator cuff, latissimus dorsi is a good candidate, or even teres major. I'm going to show you an example because it can simulate the line of pull and the function of the posterior superior rotator cuff. The most common tendon used in the shoulder is the latissimus dorsi, followed by pec major, but there are other tendons which are used. I'm going to focus on the latissimus dorsi, which can be done with or without teres major. And that's typically performed for patients with massive, non-reparable posterior superior rotator cuff tear to restore shoulder function. Before going through that, I just thought that it would be important to just review the anatomy of the latissimus dorsi, which is a large fan-shaped muscle taking origin from the spinous process of the T7 to L5, the iliac crest, most inferior third and fourth ribs, and oftentimes it basically run over or has some attachment, sometimes fibrous attachment to the inferior angle of the scapula. After that, it becomes a long tendon, about 7 centimeter, which passes anterior to the teres major and inserts into the bottom of the intertubercular groove of the humerus, anterior to the teres major tendon insertion and medial to the pec major. So if you want to find the tendon on MR, the easiest way, I think, at least to me, is that I try to scroll down and first find the pec major attachment tendon insertion to the lateral to the course of the long head of the biceps. At the same level, that you can find the latissimus dorsi tendon by finding the short head of the biceps and coracobrachialis anteriorly and teres major tendon posteriorly, and you see this long low signal, which is the latissimus dorsi tendon. By just looking at the function or at the orientation of the latissimus dorsi, you can see that if they cut the tendon and bring it on over to the posterior superior humeral head, it can function as more posterior superior rotator cuff. And that's what happens during procedure. The latissimus dorsi tendon is harvested from its humeral attachment. The harvested tendon is passed through the soft tissue plane, deep to the deltoid, and posterior to the teres minor. The tendon graft is then sutured to the lateral aspect of the greater tuberosity, and that can simulate the posterior superior rotator cuff function, which is external rotation and humeral head depression. Here's an example of the latissimus dorsi muscle tendon transfer. You can see that on the coronal T1, the transfer of the latissimus dorsi tendon, as you can see here, is a long tendon going again posterior inferior to the teres minor, the attachment of the at the posterior superior humeral head, and you can see a part of the latissimus dorsi muscle and myotendinous junction here. The coronal proton density. Unfortunately, they've used fat suppression, and which, as I said in the beginning, shouldn't be a problem. For some reason, they have used perhaps some suture material that has caused this artifact. But you can still see that the heterogeneous thick tendon transfer attachment to the posterior superior humeral head, which is still intact. Again, the same thing applies. Unfortunately, I did not have any cases of the failure of muscle tendon transfer to include, but the same rule applies here. If there's a fluid gap or empty footprint, you might consider the retear of the graft material. And lastly, that is I think, subacromial spacer implantation. I have to say that I haven't seen any case myself. Um, it would be interesting to see if others have seen a case. I know that in Europe, they probably use this more. And what it is basically there's an implantation of the spacer utilizing an inflatable balloon, which is made of biodegradable synthetic material. The balloon is inflated with physiologic saline and expands the subacromial space. And the idea is to reduce friction, which helps to bring the humeral head to the center of the glenoid during shoulder movement. They introduce the balloon via an arthroscopy portal into the subacromial space, and then inflate the balloon inside the body. And interestingly, the balloon is expected to deflate after 10 weeks, and the deflated balloon material is resorbed completely after 15 months. So I'm not sure about the long-term effect of this surgery, but there are studies which have shown short-term pain relief and improved function after surgery. So here is an example that I got it from the literature. The normal appearance of the spacer is before it deflates, and yet it still has saline in it. There's a T2 hyperintense structure. And on a T1, there's an intermediate signal in the subacromial space. It can create sometimes scar tissue after a while, which is expected. And as I said, this is an example from the literature. So that brings me to the end of my talk. So in summary, the advanced arthroscopic and augmentation procedures used in some of the newer surgical techniques for treatment of massive rotator cuff tears are providing a favorable outcome and gaining more popularity among some orthopedic surgeons. So an MRI, as we know, is a powerful tool with which to evaluate these surgeries and post-operative of these patients. So I think it is very important for us to be familiar with their post-operative normal appearance and knowing the complications and possible potential pitfalls. Again, I want to thank you for inviting me, and I'm glad to take any questions.
Thank you so much. Excellent talk. We did have a couple of questions come in. The first is, in the first year following rotator cuff repair, is there any guideline that you know of about injecting corticosteroids in the joint or the bursa for pain management and for the setting of postoperative adhesive capsulitis?
That's an interesting question. At least I know in our institutions, surgeons usually do not ask us to inject cortisone in early post-operative rotator cuff repair. One reason is that they would like to wait and see how the patient does. I think they follow a very strict post-op rehab regime, and I have not seen our orthopedic surgeons use that or ask us to do cortisone injection specifically for adhesive capsulitis within the first year. I do not know anything. I don't have anything I can think of any particular guideline in terms of whether it is advisable or not. But at least at our institution, I have not seen our orthopedic surgeons want that. And I think one reason would be maybe it can interfere with healing of the graft or the repaired tissue. But I haven't seen those. I don't know what your experience is.
Got it. I don't actually know if there's a set guideline, so I don't know how to answer that either. The second question was for the general postoperative appearance. They said T2 signal, increased T2 signal was associated with granulation tissue. Is it well known if this could be attributed to fat infiltration within the repair?
Very interesting question. So The tendon itself, I'm not aware of fat infiltration of the tendon. If they're referring to the muscle, I think it's very important. It's extremely important to look at the muscle. Um, if there is progression of the fat infiltration of the muscle compared to the pre-op MR, I think that should raise the suspicion that this is not working. There's something not working, and then probably we have to scrutinize the tendon more carefully. But in terms of this tendon itself, the signal heterogeneity is technically attributed to scar, granulation tissue, suture material, and it depending on what kind of if they've used if that was a primary repair, there's always some residual tendinosis which can remain for after surgery. If there is a graft, that might be just part that's might be the expected postoperative appearance.
Got it. Have you seen anyone using latissimus dorsi or other tendon transfers in the setting of infraspinatus musculotendinous junction tears that are missed and subsequently atrophy?
That's a great question. Actually, I have seen two of these cases at our institution. Um, the latissimus dorsi that one of our surgeons used in a 19-year-old who was I think was born with some sort of delivery-related neuropathy and had isolated posterior and posterior superior rotator cuff weakness, namely infraspinatus and teres minor. And the patient did not have any rotator cuff tear, and ultimately they used latissimus dorsi to replace the function of their infraspinatus and teres minor when it was a functional failure of posterior superior rotator cuff. So that I think I would say yes to that answer. I have not seen a case. I don't think these are that common, but I can imagine if they can use that transfer to replace the posterior superior, posterior inferior, and posterior superior cuff, they can also use it in all sort of tear. But that's a great question. I haven't seen a case.
Got it. The last question that came in was just about the frequency of surgeries. And the author of this question is at an academic center where they see a lot of sort of cutting edge surgery, and mentioned that their surgeons have sort of moved away from patch grafting and capsular reconstruction due to outcomes that they've noticed. The question was how frequently you're now seeing patch grafting and superior capsular reconstruction.
Oh, that's a great question. As I was talking to Adam before the meeting started. Patch graft, I don't remember the last time I saw a case. So I totally agree with the comment. The superior capsular reconstruction, we were seeing cases before COVID. I have to say I have not seen personally any case of superior capsular reconstruction after COVID, and I do not know how much of it is related to the COVID that was hit the New York City, or is the outcome of the surgery. We did a study on our all of our supercapsular reconstruction cases, a total of 50 over a period of 8-9 years. And unfortunately, not all of them had MRI. About half of them had MRI, and so 24 something MRI. Half of them had tear of the supercapsular reconstruction. Interestingly, we found that even those half had great outcome after surgery, at least short term. So it would be interesting to see a longer term outcome. But I think I can just think that it might have affected some of our surgeons' um, desire to do surgery. Again, I think if you look at the literature, I think there's different outcomes coming out. The Japanese are getting a great result, even longer. They started first. I think they're getting more long-term outcome, but they're using more of the fascia lata autograft. But I agree with the comment. I don't think we see as many as we used to.
Fantastic. It was really an excellent lecture, and we're all definitely learning from the experiences that you're seeing, and we appreciate you taking the time to share your cases with us and your knowledge. So thank you so much. That's the last question that I have. So that will wrap it up for today. Thank you all very much for attending, and I'll upload this video later today or tomorrow. And everyone try to stay safe. Thank you.
Thanks again. Thanks again.
Take care.
Bye-bye.
Bye.
Bye.